Hello student, I am Dr. Arulprakash from the Department of Orthodontics. I am Associate Professor from Vinaya Mission Sankaracharya Dental College, Salem. My topic is about management of class 3 malocclusion. So we all know that angles have classified the malocclusion into class 1, class 2, class 3. So for class 3, the mesiobuccal cusp of the upper first molar occludes with the interdental space between the mandibular first molar and the mandibular second molar. So if you see extraoral features, the facial profile will be concave. So in class 3 malocclusions, the most problem will be there maxillary deficiency growth and the mandibular overgrowth, that is mandibular prognathism or maxillary retrognathism. If you see in this first picture, here if you see the maxilla is deficient and the maxillary dentition is also deficient. And if you see in the second picture, you can see the mandible is overgrowth and the mandibular dentition is also forwardly placed. If you see in the third one, both combination of the both, the maxilla and the maxillary dentition is backwardly placed and the mandible and the mandibular dentition is forwardly placed. If you see intraorally, you can see the anterior crossbite. You can see here the anterior crossbite. Posteriorly, you can see crossbite unilaterally or bilaterally. If you see occlusal view of the picture, the occlusal view of the maxilla will be more constricted when compared to the mandible. See what are the extraoral features of class 3 means? You have concave profile, the profile will be more concave, the maxilla will be retruded and the mandible will be prognathic. You see the lip step, you will have a positive lip step. You can see here, the lip step will be positive. If you see the cephalometric analysis, what are the norms, basic norms we have to see is SNA angle. This is the S point, sella point, we all know that this is the nasion point, the point A is on the maxilla. These 3 points we will take. So the normal value is 80 to 84. If it is less than that, it shows the retrognathic maxilla. If you see S and B, S, N, this is S and this is N and this is B. If you see S and B, the normal value is 80 to 82. In class 3 cases, if you see, it will be more. It will be more than 83. And if you compare this A and B angle, this is point A and this is B, A and B angle, it will be, the ideal A and B angle should be 2 degrees. And if you see in the class 3 cases, it will be in minus. So width appraisal is, it should be 0 mm. Comparing the maxilla to the mandible, that should be 0 mm. And n perpendicular to point A, it should be 2 millimeter, and n perpendicular to point Pogonion, it should be 0 mm. And from condyle to gnathion, it should be 23 millimeters at the age of 12 years. If you see the prevalence of class 3 malocclusions, if India, it is 1.19% only globally. And if you see the East Asian, South Asian, it will be around 15, 14 like that. If you see nationality wise, the Chinese, the Malaysians and the Japanese and the Koreans will be more common for class 3 malocclusions. Coming to India, the percentage is 0 to 4% only. We have to know clearly about the etiology of malocclusions. Mainly for the class 3, the studies of human inheritance have provided sufficient evidence to establish the fact that the mandibular growth is mainly affected by the hereditary. We all know that this Habsburg's jaw is commonly among one European family. So coming to the environmental factors, so wrong posterior habit of the mandible which pathologically alters the mandibular condyle position within the fossa. As a result, the mandible slides forward. The various other factors such as the growth stimulus and the history prolonged sucking, resting the tongue habits. The main thing, if you see, due to habitual positioning of the mandible more forward, the condylar, the posterior part of the condylar fossa will be empty. So there will be a growth in the condyle. So that will naturally position the mandibles more forward in position. So they look like class 3 patients. So the other various factors such as the growth stimulus and the history of prolonged sucking habits or tongue thrusting habits, in some tongue thrusting habits, you can have the skeletal class 3 malocclusions. And the functional mandibular shift, if there is any respiratory obstruction like tonsils and adenoids, the patient can't breathe through nose. So what they used to do, they will try to breathe through mouth. So if they try to breathe through the mouth, what they will happen, they will put the mandible downward and forward position. So there will be an empty space in the condylar space. So there will be a posterior growth of the mandible will be there. So the mandible will shift towards anteriorly, and you can see that the patient will look like a class 3 malocclusion. If there is an alteration in the pharyngeal airway space, so the patient will put the mandible forward. If there is any hormonal imbalance and disturbance such as the pituitary hormone and gigantism, the mandible will be more forwardly placed. And due to trauma to maxilla or mandible in the early age, that will alter the growth of the maxilla and mandible. So that is one of the environment factor for class 3 malocclusions. And premature loss of the primary posterior teeth. If the posterior tooth got prematurely lost, so they won't have support to place the mandible in the most posterior position. What the patient try to do, they will put the mandible forward and they will try to occlude in the anterior tooth. So that plays a major role in repositioning of the condyle, leads to class 3 malocclusion. In congenital anomalies such as the cleft lip and cleft palate patient also, you can have class 3 malocclusions. In muscle dysfunction and in combination with other environmental factors plays a major role in the class 3 malocclusions. So before going into detail about the treatment of class 3 malocclusion, we should know clearly the timing when we have to start the class 3 malocclusion treatment. Unlike other orthodontic cases, we should not think about the treatment for the class 3 malocclusion and class 2 malocclusion is after the completion of all the pubertal growth spurt, that is after 14 or 15. It's not like that. For class 2 and class 3, the timing is there, particular timing is there for treatment of orthopedic corrections. When coming to class 3 malocclusions, the ideal timing is the pubertal growth spurt. For girls it should be 8 years or boys it should be 9 years to do the functional orthopedic corrections. So we should know little bit detail about the growth spurt before going in detail about the treatment. So what do you mean by growth spurt is the timing of growth for boys and girls. At certain age the growth will be at peak. So that is called a growth spurt. So the growth spurt will be differs from boys and girls. The growth modification appliance responds more during the growth spurt. So if you want to give any growth modification appliances, so you should give during the growth spurt. That is the important thing that we should know clearly. So the patient should wear the growth modification appliances until the growth spurt is over. If you are giving any myofunctional appliances, so the patient should wear the myofunctional appliance till the growth gets completed as a treatment part and as a retentive part. If you stop in middle, so the relapse will happen. So you should take care, the appliance should wear till the growth gets completed. So the timing of growth spurt for boys and girls it will vary. In mixed dentition the boys is 8 to 11 years, for girls it's a 7 to 9 years. Pre-pubertal growth spurt for boys it's 14 to 16 and girls it's 11 to 13 years. So if you want to do any treatment, so the pre-pubertal growth spurt and during the peak or growth acceleration period, the response will be more for growth modification or myofunctional appliances. So that is the main thing we should know. So we should know about the Scammann's growth curve also. So if you see the Scammann's growth curve, the different parts of the body will grow at different timing. So if you see the maxilla and mandible, the maxilla will attain the peak at the age before 10 years. If you see the mandible, after 10 only it will get to the peak growth. So if you want to do any corrections for the maxilla, you want to give a myofunctional appliance at the age before 11 years. So the mandible are going to follow the neural tissue, it's a brain, so skull. So if you want to give any myofunctional appliance for maxilla, you should follow this Scammann's growth curve. So at the age of 10 years, the 90% of the maxillary growth will get completed. At the age of 13 to 14, 90% of the mandible growth gets completed. So if you want to give any myofunctional appliances or orthopedic changes to the maxilla, you should start early. For mandible, you can have a timing. It means for 13 to 14 years. So what is the main clinical implication here is the maxilla growth ceases very early when compared to the mandible. So skeletal modification in maxilla should do very early. So how to know the skeletal growth is there or not? So to identify this, we should know some skeletal maturity indicators. So these are the basic things about the growth and the growth maturity indicators we should know very clearly for treating the myofunctional appliance or skeletal problems in class 2 and class 3 cases. Rest all the cases you no need to see the skeletal maturity indicators, normal severely crowding cases or severely spacing cases at the age of 13, 14, 15, 16 and all. But if the patient is in skeletal class 2, prognathic maxilla, retrognathic mandible or prognathic mandible or retrognathic maxilla, you should know the skeletal maturity indicators and the timing for the treatment. So among the skeletal maturity indicators, lot of skeletal maturity indicators are there like hand rest, cervical vertebra, mid-palatal suture, antegonial notch, symphysis and frontal sinus, lot is there. So the main thing we should know is only the hand rest radiograph and CVMI. In this, I am going to talk about the Hang and Taranger method of hand rest radiograph. Now, this is the very simplest way. If you are seeing a patient on the day itself, you can do it in your clinic. So you just take an IOPA, put it in the middle finger, middle phalanx. This is the middle phalanx. You just put an X-ray IOPA down, ask the patient to put the palm there, and there should not be any rotation in the fingers. The fingers should not get rotated. So that is the main thing. And you just put the X-ray perpendicular to the finger. Should be very perpendicular, and you can expose it and you can take it. If you take exposed X-ray and if you develop, you will get an X-ray like this. So there are 3 stages. What are the 3 stages means? Epiphysis is equal to the width of the diaphysis. This is the epiphysis, this is the diaphysis. So if you see, it will be equal, or you can see an capping, or you can see an fusion. These 3 things you can see in the patient. So that is MP3 is nothing but it's a middle phalanx, third finger. According to Hang and Taranger, he had divided into stages. In F stage, the epiphysis is as wide as the metaphysis. So if you see the epiphysis, it will be as wide as the metaphysis. So this shows that the start of the curve of the pubertal growth spurt. The pubertal growth spurt is getting started for that patient. The skeletal pubertal growth spurt is getting started. So the next stage is FG stage. Here the epiphysis is as wide as the metaphysis. So the distinct medial and the lateral border of the epiphysis forms a line of demarcation at a right angle. You can see this right angle here on both the sides. This stage shows this acceleration of curve of pubertal growth spurt. So these things you can see very clearly if there is any rotation, if there should not be any rotation in your patient's finger. The patient's finger should not rotate it while taking the X-ray. Then you can see clearly these things. Next stage is the MP3G stage. Here the side of epiphysis have thickened and caps its metaphysis, forming sharp distal edges on one or either side. You can see this sharp margins here like this. It will get started. This is the maximum point of pubertal growth spurt. And MPH stage. Here you can see the fusion. The epiphysis will get started fusion with the metaphysis. This shows the deceleration of the curve of the pubertal growth spurt. So here the skeletal growth of the patient is going to get lesser, completed. It's going to come this side. So I stage is fusion of epiphysis and metaphysis completed. You can't see 2 distinct bones here. See in F stage, FG stage and stage G stage and H stage you can see 2 bones separately. But in H stage you can't see. You can see only 1 bone. It will get fused. This shows that end of the growth spurt. So if you are getting a class 3 cases or class 2 cases, if you want to do any growth modification changes, you can give during acceleration period. If you want to do, if a patient is coming at this stage, I stage, that is after 14, 15, 16 or 18, 19. So you can take an X-ray and you can confirm that the skeletal growth of the patient gets completed. So if you want to do any surgical corrections, you can do any surgical corrections after this. You should not do any surgical correction for class 3 or class 2 management during the growth spurt, because the skeletal growth is left out more for that patient. So if you do any corrections, the rest growth will alter the surgical part. So again you will get a relapse. So this is the main thing you should know during the correction of class 2 and class 3 cases for myofunctional or skeletal changes. So this is the summary of this one. If you want to do any myofunctional changes for class 2 or class 3, you can do F or FG or in G stage. So this is the class 3 malocclusion classifications. If you get a patient of class 3 malocclusion, the first thing you have to see whether the patient is a growing or non-growing. This is the main thing you should see. If the patient is a growing, you have to find out whether it's a skeletal or dental. If it is a dental, you can do only the orthodontic treatment. That is the most important thing. You have to see, differentiate skeletal or dental. If it is a dental, you can finish it, do only the orthodontic correction. If the patient is a skeletal, so we have to see whether the maxilla is at fault or the mandible is at fault or the combination of both. So if the maxilla is fault, the maxilla might be retrognathic. So you have to bring the maxilla forward. So with the help of face mask, protractor face mask. If the mandible is at fault, so we have to resist the mandible by giving a chin cup. So if you resist the mandible, the maxilla will grow forward and it will catch up with the mandible. So if you have both mandibular prognathism and maxillary retrognathism, so what you have to do, you have to give a face mask followed by a chin cup, or you can go for other myofunctional appliances like Frankel with you have to give chin cup. So if a patient is a non-growing, so these things growing or non-growing, you will find out with the skeletal maturity indicator as we had seen in the previous slides. So if a patient is a non-growing, then again here also you have to find out whether this is a dental class 3 or skeletal class 3. So if it's a dental class 3, straight away you can do some extraction procedures and you can finish the case with only fixed appliance. If it is a skeletal, so how it is? It is mild to moderate class 3 or severe class 3. So mild to moderate class 3, you can do a camouflage. Camouflage is nothing but you are masking what the problem is there. You just imagine mild class 3 is there, mild reverse overjet is there. If you extract single tooth or two tooth in the lower incisors or lower premolars, you will get a space. So with that space, if you retract the lower anteriors or lower dentition, so you will get a normal occlusion, class 1 incisor relationship. So you are masked the class 3, mild class 3 malocclusion. So that is called camouflage. In the same way, you can do the camouflagic treatment in the class 2 cases also. So in severe class 3, you have to find out whether the maxillary retrognathism or mandibular prognathism or the combination of both. If only the maxillary retrognathism is there, the surgical procedure is you have to bring the maxilla forward. If you have the mandibular prognathism, you have to take back the, surgically you have to take back the mandible. So the surgery you have to do it after the growth gets completed, as we had seen in the previous slides. That is the most important thing that we should know. So Turnip et al. Had given some criteria, what are the positive and negative factors for class 3 patient for intercept, to intercept the class 3 malocclusion in the early stage. So what are the positive factors means convergent facial type. The convergent facial type is nothing but the maxilla is growing downward and the mandible is growing forward, upward. So divergence means both are going in an opposite direction. If both are going in an opposite direction, with the help of myofunctional appliance, you can't intercept these corrections. It's very difficult. So better you have to wait till the growth gets completed and you can go for a surgical treatment. So in convergence, so it will be very easy to go for myofunctional corrections. If there is an anterior posterior functional shift is nothing but, so you can see these pictures here. See in the first picture, you can see anterior crossbite is there. See in the second picture, you see we just push the mandible backward, so it had come to edge to edge. So the patient, ideally the patient's position is edge to edge. For comfort zone, what the patient had done, no, so they had put the mandible forward, so it had resulted in class 3. So prolonged position of the mandible in the forward position leads to skeletal class 3 malocclusion. This case we will see detailed in upcoming slides. And if you see this frontal picture, this last picture you see the incisors are in class 3 relationship. Here we just push the mandible backward, so the patient can take back in functional shift. The patient can take back the mandible, so the mandible will move forward. So this had come to in edge to edge position. That is the anterior posterior functional shift. So if you want to intercept, if there is a functional shift, you can do. If there is no function, even in pure skeletal class 3 cases or severe class 3 cases, the patient was not able to take back the mandible. So in that case, to intercept it will be very difficult. So if you see the x-rays, the growth of the condyle should be symmetry. If you see the shape of the condyle or length of the condyle should be symmetry. If there is an asymmetry, it is very difficult to intercept the class 3 malocclusion. The patient should be young, subject with remaining growth should be there. If growth gets completed, you can't intercept. So you have to go for surgical correction. So the patient cooperation is more important thing for the class 3 or class 2 myofunctional corrections, because the appliance will be more bulky, the patient has to wear. So before going to discuss the treatment details to the parent and the patient, you should show what the appliance is, how it should be, and how they are going to wear it, and what's the size, everything you have to discuss in detail. Because nowadays, if you see the patient's thought by seeing the medias, they might think like it will be simple, small, like that only. So if you take all the records and if you prepare the appliance and if you show the face mask or chin cup or headgear, by seeing that appliance shape and size, the patient will say, no, we didn't expect this, so we don't want like this, like that they will say. So you have to explain mainly the class 2 and class 3 cases if you are going for any myofunctional appliance corrections. So you have to spend lot of time to the patient and the parent. What is the problem when compared to others? What is the problem you have when compared to others? So for this complaint, you have to wear this appliance only. This only will correct your problem. Later you will get the fixed appliance later. That is the second part, like that. You have to explain it in detail. Then only the patient will wear this appliance. So the patient cooperation is the most important thing for wearing the myofunctional appliance. And to intercept, there should not be any familial history of prognathism. If there is any familial history, you have to wait till the growth gets completed. You have to go for an surgery. And the facial aesthetics also should be good. If it is a poor facial aesthetics, so if you see in a convergent, the both maxilla is going upward and the mandible is going backward. So the poor facial aesthetic will be there. So in that cases, it is very difficult to intercept the class 3 malocclusions. So coming to the treatment of dentoalveolar crossbites. So you can do it in a removable appliance also, in myofunctional also, in surgical or in bone anchored myofunctional appliances also. So removable appliance, we all know that it's a simple inclined plane, or with the active Hollis appliance with the Z spring. So these cases we will see in later slides. So myofunctional appliance, reverse twin block, Frankel, or protraction face mask, or reversible headgear, chin cup. Bone anchored myofunctional appliance is nothing but using screws or tats in maxilla and the mandible intraorally. And surgical corrections, after the growth gets completed, the patient wants any surgical correction, or if the patient is coming as a non-growing patient, you have to definitely do the corrections in surgery only. Then you have to check the skeletal maturity indicators, everything, and you have to discuss with the surgeon. And if you want to do any pre-surgical orthodontics, you have to do the pre-surgical orthodontics. Or if you want to do surgery first, and if you want to do the orthodontic corrections later, you can do a later orthodontic correction. Nowadays in recent trends, with the 3D visual imaging softwares, lot of softwares are there. With that you can take the patient's photos, cephalometrics and a CBCT, and you can put it in that software and you can do what are the alterations you want to do. You want to bring the maxilla forward, how many millimeters you want to make, 1, 2, 3 like that, and mandible also if you want to take back. Everything you can do it with the 3D imaging softwares, and you can show that image how you are going to look after the surgery to the patient clearly. In olden days it was not there. That is in recent trends it was very more advantage for the patient also, for the doctors also to plan the treatment plan. That is a recent trend in surgical orthodontics. You can do all the corrections and you can show the patient and you can get an approval and you can start the surgical corrections. This is a simple inclined plane. You can see the reverse overjet in the single tooth. This is the inclined plane. Either you can give as a removable or fixed. Removable, the patient can wear it and the patient can remove it during brushing or like that. Fixed means you can fix it with the cement. Only after the tooth get corrected you can remove it. Some of the patient lose the appliances sometimes, so it's very difficult for you to make it again. So if you want to make it a fixed, you can make it as a fixed inclined plane. So this after the treatment of 2 months. So this is after 7 months of single tooth crossbite correction with inclined plane. If there is any retained deciduous tooth, so what will happen to the permanent tooth? It will erect palatally. So this is the extracted tooth. So after you extract the tooth, if you see, the patient will be in dental class 3. So to correct this dental class 3, you can give an Z spring. This also you can give it as a removable or fixed. So make a Z spring, activate it and give it to the patient. You have to instruct the patient how to wear, how to remove it, how to clean it and how to maintain it. So this is the treatment result after 20 days. So these things you have to do it. If you see the crossbite, you have to do it as soon as possible and you have to explain the patient what are the drawbacks if you left it there. So you have to correct it with the Z spring. And coming to the growth modification appliances, one important principle that we should know. If you start too early, it will take too long. The patient has to wear the appliance for longer period of time. So if you start too late, it doesn't work. So that is, if you start before the pubertal growth spurt, so it will take longer time. If you start too late, it means after the growth gets completed, you won't get any growth modification changes. So the timing is the most important thing, as we discussed in the growth spurt. So this other appliance is the reverse twin block appliances for class 3 correction. So what will happen if this is the patient in class 3 molar relationship, here the twin block will take the mandible backward and bring the maxilla forward. This is after correction. And the next one is the Frankel appliance, functional regulators. What the functional regulators will do, here the labial bulb is there, this will give pressure on the lower anteriors, so the lower anterior will move backward. So the lip pads are there in the upper vestibular region. The lip pads, what will happen, this will give a pressure on the lip, so this will stretch the periosteal muscle. So due to the stretch of the periosteal muscle, what will happen to the maxilla inside, this will get free from the pressure of the lip, so this will move forward. Here buccal shield on both the sides, because the maxilla is constricted in class 3 cases. So if you are relieving the pressure from the buccal side and if you incorporate the spring, coffin spring inside intraorally and the palatal side, if you activate that, the coffin spring will give a buccal movement of the tooth. So the pressure from the buccal side will be relieved by the buccal pad. So the maxilla will expand automatically, the crossbite will get corrected in the posterior segment. From the anterior segment, the springs will be there on the palatal side, as we had seen in the previous slides, like Z spring, there will be spring will be there to push the maxillary anterior forward. The maxillary anterior will come forward. So the class 3 will get corrected during the growth period. This is the reversible headgear. Lot of types are there. So the most commonly used nowadays is the petite type, this one. This is the framework. This is the frame and this is the forehead cap and this is the chin cap. This is the extraoral elastics holding point. This is the metal frame which connecting these devices. Hereafter we will see the cases. So this is the class 3 case. You can see the class 3 clinical features. Midface deficiency is there for this patient. Maxillary anterior intraoral, if you see the maxillary anterior crossbite is there. So this is the bondable Hyrax screw with elastic holding loop on both the sides. This we will cement it inside and you have to activate the screw 1 quarter turn per day. If the patient is growing at a younger age, 1 quarter turn is more than enough, because the maxillary sutures won't intact that much. So very mild force is enough. So once you see that midline got open after 10 days of the treatment activation, so you can start using the reversible headgear and you can give an elastics from the hook. So we had given a hook, from this hook you will give a elastics to this hook. So this is the timing of photograph we have taken in the various time. So this is a pre-treatment, the first photographs are the pre-treatment. This is appliance wearing is during treatment after the completion of the reversible headgear. So this is 7 years after the reversible headgear treatment. The patients, all the permanent dentition got erupted. So you can see dentally, now you can see dentally spacing is there in maxillary anteriors. So this is the extraoral smile photograph after the myofunctional therapy, and now the patient is under the fixed appliance therapy for this space closure. This is the second case. Here we are going to see the crossbite in the anterior region. This is the thing I just want to show you. After the activation of the screw, so you can see the mid-palatal suture got opened. This is the clinical sign of mid-palatal suture opening. You can see the midline diastema. If you want to see clearly, you have to take a CBCT or occlusal view radiograph, and you can see the mid-palatal suture is get separated or not. So this is the main clinical sign. The midline diastema will get open. So after that, you can give an reversible headgear. With this, you have to give an elastics extraorally, and you will connect to this hooks on both the sides. So this is the pre-treatment. You can see this midfacial deficiency here, and you can see the midface has come forward. So this is another case of age 13 years. You can see unilateral crossbite. In some class 3 cases, if you see, the crossbite, posterior crossbite will be unilateral only. In some other cases, you can see bilateral. Anterior crossbite is also there. In this case, you can see the crossbite only on the right side. In left side, there is no crossbite, and the anterior crossbite is there. So if you see the clinical extraoral clinical features, you can see the midface deficiency is there, and you can see the positive lip step. The maxilla is back and the mandible is forward. So the treatment plan was started with the maxillary expansion with the Hyrax screw, bondable Hyrax screw. Mostly the bondable Hyrax screw is more advantage when compared to the bandable, because in banded type research shows that there will be an extrusion of the posterior teeth. So bondable is the best thing, and after 10 days of activation, you can see the midline diastema you can see here. So after the midline diastema appears, you can go for an wear of the extraoral devices. So you can see that buccally both the posteriors came out, and the anteriors also the reverse overjet got corrected. This picture is after the removal of the intraoral device. The second picture is after the removal of intraoral device, and you have to wait for some more time for the posteriors to get settled down. Once the posterior got settled down, so you can go for a fixed appliance therapy. During the fixed appliance therapy, you have to give an class 3 elastics. Class 3 elastics is nothing but you have to give an intraoral elastics from the molar to the canine. From the initial stage itself, you have to maintain this class 3 elastics till the treatment gets completed. So this is the smile photograph of an patient pre-treatment. The first one is the pre-treatment, and this is the post-treatment. And you can see this frontal photograph pre-treatment and post-treatment. You can see this lip step, positive lip step. Here you can see the lip step got corrected. And if the patient is purely mandibular prognathism, if mainly for class 3 patient, the main thing is the family history is the most important thing that you have to ask. You have any family history is there. If the patient had a family history of prognathic mandible, better to wait till the growth gets completed. You can directly go for an surgical correction. You no need to go for any interrupt. If you want to interrupt the correction, you can resist some amount of growth, and you can maintain to little bit, and you have to wait till the growth gets completed. And after the growth gets completed, you have to take a radiograph, and you have to see the skeletal maturity indicators. All the fusion of the metaphyses are seen, or in CVMI stage the growth gets completed or not. Then you have to take the patient to the surgery, and you have to discuss with the surgeon what we can do for this case, and if you want to do any 3D visual treatment corrections, then do all the corrections, show the patient, get the consent form signed, everything, then you can go for a surgery. So if there is no family history, and you can go for chin cup therapy for the correction of class 3 malocclusions. Either you can give for occipital region, or you can give an vertical region. If patient is having little bit of open bite, you can give from the vertical. So what will happen? The pressure from this side will correct this open bite also. If the patient is an horizontal grower, you can give an occipital pull chin cup therapy. So this is one case. You can see the mandibular growth is more. This case we had already discussed that due to the habitual position, the patient had placed the mandible more forward, but the patient can take back the mandible little bit. So here the patient is in reverse overjet. If you push the mandible backward, here you can see the patient can take it back little bit. Due to the habitual position, see the mandible how it had gone more forward, and see the lip step. So here the patient is not willing for surgery, so a little bit of space is left out on the lower anterior segment. So the treatment plan was to close the space and to bring the maxilla and mandibular dentition in proper occlusion. So this is called camouflage. So this is, in this case if you see both the molars are in class 1 relationship, only the anterior crossbite and the upper anteriors are inside, the lower anteriors are backside. So this is the dental class 3 case. So you can see the lip is normal. So this is a dental class 3 case. The plan was to do the correction with the only purely orthodontic corrections. So everything was bonded, upper and the lower arch was bonded with the fixed appliance, the bite was raised for osteotomy. If you want to take the maxilla forward, so the surgery is leaf-odon osteotomy. They will split the maxilla from the naso-alveolar complex, and they will put the maxilla forward how much they want, and they will do a plating. So if there is a retrognathic maxilla and prognathic mandible, so what we have to do? We have to do a by-jaw surgery. So by-jaw surgery is nothing. You will take the mandible back and put a screws, BSSO. In maxilla what you will do? You will bring forward the maxilla and the surgeons will put a screw. So this is surgical treatment option. So this how it's going to be after the surgery gets completed. We have to do the 3D visual treatment plans, show the patient how you are going to look after the treatment like this only. These are the corrections we are going to do, get approval. If the patient is willing for surgery, we can do a surgery. And in recent days, due to the use of TADs, temporary anchorage device. Temporary anchorage device is nothing but it's a mini screws. They will put on the infrazygomatic region or interradicular or in the ramus or in the symphysis like that. That is called TAD, temporary anchorage device. So with the help of the temporary anchorage device, patient no need to wear. But if you see the extraoral appliances, it's more patient can't wear full time like that. But if you put an intraoral screws like this, surgically if you put an intraoral screw and if you put an class 3 elastics, so the patient can wear the elastics intraorally for a full time. So nobody is going to see this elastics. So if you see extraoral device, it's very difficult for the patient to wear for the full time. So the patient will wear only during the evening or in the home time only. So TAD, with the help of the TAD, they can wear full time. So the result will be more faster and you will get a good result in the bone anchored maxillary protraction appliances. So coming to the classification of true and pseudo class 3. Here in true class 3 you can have a skeletal pattern. The skeletal pattern will be prognathic mandible or retrognathic maxilla. But in pseudo, usually the class 1 skeletal pattern will be there, mild skeletal class 3 pattern will be there, or the mandible will be placed anteriorly due to any functional shift or due to some endoendodental fractures. The patient might have placed the mandible in a forward direction. So the patient's profile will be concave. Here the patient profile will be straight or mild convex. So etiology is usually hereditary, true class 3. The etiological factor might be functional due to habitual or a certain dental premature contact, or some skeletal fractures will be there. So here there won't be any premature contact won't be there in true class 3, but in pseudo class 3 premature contact will be there. Due to that premature contact only, the patient will place the mandible in the forward direction. So if you relieve that premature contact, the patient can take back the mandible and they can place it in a normal occlusion. So the retrusion of mandible is not possible. So you can't, the patient, if you push the mandible also, the patient can't take back the mandible. But here in pseudo class 3, if you push the mandible backward, so the patient can take back the mandible little bit. So with that you can identify whether it's a true or pseudo class 3. And you have to see the cephalometric findings also, whether the patient is truly skeletal class 3 or not. So coming to the summary at last, so if you get a class 3 patient, the main thing you have to find out whether the patient is growing or non-growing. That is the most important thing that we have to see. The patient family members has any class 3 mandibular prognathism, like that, more than enough, like inclined plane or Z spring. If the patient is a non-growing, whether you have to find out whether it's a dental or the skeletal class 3. If it's a dental class 3, you can correct it with an orthodontic appliance, or mild class 3, you can, if you want to do some camouflage extraction of 1 or 2 tooth in the lower jaw and take back the lower dentition backward, and if you want to finish it in the occlusion, so that is more than enough. If it is a true skeletal, so you have to find out whether the maxilla is at fault or mandible is at fault. If the maxilla is at fault, the surgery is the leaford one, put the maxilla forward and the platings will be done by the surgeons. If mandible is forwardly placed, they will do an BSSO, bilateral sagittal split osteotomy. They will take the mandible backward and they will put a platings. If combination is there, maxilla is set back and mandible is set forward, they will put the mandible back by BSSO and they will bring the mandible maxilla forward and they will do a platings. So they will put it in an occlusion. So that is the surgical treatment option for skeletal class 3. So the main thing, coming to conclusion, the main thing, if you get a skeletal class 2 or class 3 cases, the main thing you should know whether the patient is a growing or non-growing, and you should know about the growth spurt and timing when to start the case. Either you can do it myofunctionally or skeletally. That clear idea you should have before starting the skeletal class 2 and class 3 cases, whether we can do it myofunctionally or skeletally. So I hope you have got a clear idea about the class 3 management and myofunctional appliance, and regarding the growth of the patient, we have to take in care for treating the myofunctional, treat with the myofunctional appliance or surgical treatment option. Thank you all.